Isn't it fascinating that every single piece of movement, sensation, everything to do with your face, controlled by just 12 nerves, 12 cranial nerves, that's it. And today we're going to go through those 12 cranial nerves, but not in order, not just the usual way we usually learn this, but in a specific method that helps me think about them. And we're just going to put them into groups and figure out what these groups do. And by understanding what the groups do, you can work backwards and then you can remember all the cranial nerves. So my name is Prashanth, I'm a neurologist, and I've been teaching medical students, neurology residents, and registrars in neurology for decades. So welcome to the Spiral Clinical Neuroanatomy Curriculum. I want to teach you clinical neuroanatomy and lesion localization so that you become an expert at the bedside. But I want to do it in blocks. I want you to learn the entire map of the nervous system and then come back again and go deeper and deeper. So this might start off simple, but the third time we come around, you will be a master of neuroanatomy. So let's get to it. Now, the 12 cranial nerves, very simple. You could think about the cranial nerves, which we write in Roman numerals, as just running them down 1 all the way to 12. And really, that is the boring way of doing it. Now, it is important to know these in order because when we get to the brainstem section, there is going to be an aspect that we need to understand these in an order. But the reality is they really work in groups. The first one are special senses. So this isn't your touch or your proprioception. These are to do with your special senses, your hearing, your smell, etc. So the first one off the bat is 1. Now, this is your sense of smell. So this is your olfactory nerve. So this is your first special sense, is the sense of smell. So your olfactory nerve starts in the nose. It's a sensory nerve. So the nerve terminals start in the nose and they make their way backwards to the brain. And it actually goes to the brain itself. It bypasses the actual brainstem and goes to the frontal lobe. The olfactory nerve is actually above the brainstem and it's a sensory nerve. All these special senses are sensory nerves. They're taking sensation from the end organ, which is the nose, back to the brain for the sense of smell. Now, our second nerve is to do with vision, and this is our optic nerve. And in a similar process, the nerve starts in the retina, in the eye. That's where your photoreceptors are. And they take light and they communicate that all the way back through the optic nerve. And so your optic nerve is a sensory nerve. If you remember back to our vision episode, we have individual optic nerves on either side. We have the chiasm where fibers cross and then they become tracts and radiations as they make their way back to the occipital lobe. Now the next one we're going to learn about, we're going to jump a few, is to your 8th cranial nerve. And this does 2 things. It does hearing and it does balance. And so your 6th sense is not that you see dead people, it's that you can balance. And so that is the 6th, almost our 6th sense, quite a few senses, but 6th sense we'll say is balance. And so this is your vestibulo, and that's the balance section, cochlea, and that's the hearing section, nerve. And sometimes this is also called the acoustic nerve. So these 3 nerves are your special senses. They're constantly taking back sensation. For the 8th nerve, it's taking back all the input that's coming from the vestibulocochlear apparatus, and it's taking all those impulses and it's taking all of that electrical signal and sending it back to the brain, and it's allowing you to understand where you are in space and motion, to coordinate that with your eyes and your retina, and to also hear. So these are all your special senses, and these are the nerves of your special senses. Now, I'm just going to highlight this here. So we've got 1, we've got 2, and then we've got 8 down here. Fantastic. What's the next group? And the next group is to do with eye movements. And so with eye movements, we have our 3rd nerve, we have our 4th nerve, and then we have our 6th nerve. Now, if I was to draw a set of eyes, beautiful, gorgeous, 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 gorgeous. Horrendous. Please excuse my horrendous drawing. I love it. Okay, so we've got eyes here, and I'm just going to label this as right and this is left. So this is the patient looking out at you. So what do these nerves do? They do the eye movements. They actually control the extraocular muscles, and these are the muscles around the eye to move the eyes, and they work in perfect harmony in unison to get the eyes to move. So the 3rd nerve does the bulk of it, okay? So the 3rd nerve does almost every eye movement. So we'll say almost every eye movement. Okay, and it does almost everything. It looks in almost every direction except for the fourth nerve, which innervates superior oblique, and the sixth nerve that does lateral rectus. Every other eye movement is the third nerve in this situation. So our eye muscles are the obliques and the rectis. The rectis are always right. So whatever I say lateral rectus, that's exactly what that muscle does. It's right. So lateral rectus moves the eye laterally or abducts the eye. The obliques are always opposite. So if I say inferior oblique, that's the opposite action. So it actually elevates the eye superiorly. So the recti are always right, superior rectus elevates the eye. The obliques are always opposite, superior oblique depresses the eye. When I abduct the eye and I want to look up and down, the recti muscles do that, so superior rectus and inferior rectus. And when I adduct the eye and I'm going in, if I want to look up and down, the obliques do that. So inferior oblique and superior oblique. So if I look to the right, abduction, adduction, and I look down, that's inferior rectus and superior oblique on this side. And so this is the fourth nerve that's working here. When we want to localize the fourth nerve palsy, we say, do you have double vision? Yes. Does it get better? Yes, it gets better because I'm not stressing the muscle. And I go and put the muscle in its position of action. I'm stressing it, and that's when the double vision gets worse. And they say, yeah, my double vision's worse. So those are all the eye movements. So third does almost everything. Superior oblique for the fourth, and lateral rectus for the sixth. Now, if you get a third nerve palsy, it's the classic down and out. You get everything, the entire eye, down and pointed out. The third nerve also does eyelid. So we get a ptosis, a complete ptosis. Eyelid is completely closed over and closed. So that is our third, our fourth, and our sixth. Now the next group is to do with your face. And so this is your fifth nerve, and this is your seventh nerve. And so your fifth nerve is your trigeminal nerve, and the seventh nerve is the facial nerve. Easy. So trigeminal nerve does a couple of things, and the main thing that it does is sensation to the face. And so we say that's V1, V2, V3. There's three divisions of the facial nerve. And sensation of the face, and we'll say V1, V2, and V3. There's three divisions of the trigeminal nerve. And it also does muscles of mastication. And so that essentially means chewing. So it does your masseters, it does your temporalis, and it does your pterygoids. And so these are muscles. These are muscles to chew and to eat. They're not facial expression. Whereas your facial nerve does facial movement and expression. Now there's a couple of interesting things the facial nerve does as well. And that is sensation to the anterior 2/3 of the tongue. And it also stabilizes the stapedius. So what is stapedius? Stapedius is one of the three tiny bones in your ear that is part of the hearing apparatus. Your eardrum vibrates, and those three little bones kind of vibrate along and send signal to your cochlea. It stabilizes that. It keeps it kind of like nice and stiff and a little bit rigid. So when patients get a facial nerve palsy that's pretty proximal and it affects the nerve branch going to stapedius, patients actually get hyperacusis. Sound can feel really kind of loud and sharp and very irritating. And so that is a really nice localizing sign to figure out how proximal the lesion is in the facial nerve. Now, when patients get Ramsay Hunt syndrome, and so that is essentially a VIII infection infecting the seventh nerve, the facial nerve, they will get a Bell's palsy. And so they'll get a facial droop. That's a lower motor neuron facial droop. So that'll mean forehead will be gone, they can't close their eyelid, and their face will be droopy. They can also get vesicles, and these are herpetic vesicles from the VIII in the inner aspect of the ear, which does sensation there as well, and the anterior 2/3 of their tongue. And so always look at their tongue and always look at their inner ear to make sure they don't have a Ramsay Hunt syndrome rather than a pure Bell's palsy. So both of these nerves, 5th and 7th, both do motor and sensation. But for some reason, we think of the trigeminal nerve as sensation and the facial nerve as motor, but they both do the same, and they're both important for that face, a little bit of that inner ear, and that tongue as well. So let's just highlight the face here. Face, face. And that brings us to the very bottom here. And so these are kind of, in my mind, all grouped together, and these are called the bulbar nerves. So what the bulbar nerves do essentially is they all come out of the lower aspect of the brainstem, the medulla. Kind of looks like a tulip bulb, I think. And so for that reason, it's called the bulbar region. And so when you have a palsy or dysfunction of all of these lower cranial nerves, it's to do with everything in this lower aspect of your mouth, your swallowing, your tongue movement, your speech. And so patients classically get dysphagia, so they have trouble swallowing, and they get a dysarthria, so difficulty articulating the words. So we get dysphagia and we get dysarthria. So whenever somebody comes in and says, I'm having trouble swallowing, articulating, they've got tongue wasting, their tongue's weak, we think of these lower cranial nerves, and I really bunch them all together in that way. So if we go through them in a little bit more detail, we have the 9th cranial nerve, which is our glossopharyngeal nerve. So this is the 9th cranial nerve with our glossopharyngeal nerve, and this essentially does sensation to the middle ear, posterior third of the tongue, and it does a bit of swallowing as well. Classic presentation is glossopharyngeal neuralgia, where they get dysfunction of the glossopharyngeal, so they get a sharp stabbing pain, like trigeminal neuralgia, but it's in the back of the tongue into the oropharynx, and it can shoot into the ear as well. Now it does this very small component of swallowing. It's very much overall a sensory nerve. Now, the next nerve is number 10, which is the vagus nerve. And the vagus nerve is the great wanderer. So the vagus nerve does a lot of sensation in the pharynx, larynx, esophagus, thoracic, and abdominal viscera. So it kind of does a lot of sensation all the way down here. But it's also very important for the motor aspects of swallowing, and it also carries a lot of autonomic features as well, which we're not going to go into today. So a lot of that swallowing component as well as sensation is to do with the glossopharyngeal and vagus. There's a lot of overlap between the two of these. Now I'm just going to put this a little bit to the side here, but the 11th cranial nerve is your accessory. And so this is a purely motor nerve, and what it does is your trapezius, so this movement, and your sternocleidoid mastoid, which is this muscle moving from side to side. So I'm just going to say your traps, and I'm going to say your sternocleidoid mastoid. And so there's very motor involvement of this action. And then coming back down again here, I'm going to say your final nerve, which is your hypoglossal nerve, and this is purely to do with tongue movement. So hypoglossal. And this is to do with tongue movement. So that kind of movement. So everything to do with that. So you can see why we group these together, because all of this is to do with speech, movement, tongue, everything to do with swallow. And any dysfunction in this bulbar region or the bulbar nerves causes a bulbar dysfunction, which is dysarthria and dysphagia. And so the easiest way is just to remember this. So if we were to go back here, we would once again say that these in red here are to do with your special senses. They're to do with smell, vision, hearing, and balance. Everything that we have in blue here is to do with eye movement. What we have in brown is to do with your face, to do with sensation as well as movement. And then finally here, the bulbar nerves are to do with swallowing, eating, and articulation. Next week, we're going to hit the rules of 4. We're going to hit the brainstem and the anatomy. We're going to use these specific cranial nerves to help us anchor and localize deep within the brainstem and figuring out what height we're in the brainstem as well. So stick around for more clinical neuroanatomy. Don't forget to subscribe and like. Send this to a friend so they can get involved with the learning as well. I'll see you next week.